On behalf of the International Society of Nephrology and Kidney Disease Improving Global Outcomes, KDIGO, we welcome you to this webinar on the newly updated Clinical Practice Guideline on the prevention, diagnosis, evaluation, and treatment of hepatitis C and CKD. I am Bertram Kasiske, a nephrologist and transplant physician from Hennepin County Medical Center in Minneapolis, Minnesota, and former co-chair of KDIGO. I'm your moderator today. For this webinar, everyone will be on mute to avoid background noise. After the presentation, there will be a brief quiz if time permits and a Q&A session. Questions can be asked via the question box on your screen. KDIGO was established in 2003 to improve the care and outcomes of kidney disease patients worldwide through promoting coordination, collaboration, and integration of initiatives to develop and implement clinical practice guidelines. Given the very high prevalence of HCV and CKD, KDIGO convened a group of experts to develop guideline recommendations on the prevention, diagnosis, and management of HCV and CKD a decade ago. This effort resulted in the publication of the very first KDIGO guideline in 2008. However, since publication of this guideline, treatment of HCV has changed dramatically. As recently as 2011, the only treatment for HCV was a combination of pegylated interferon and ribavirin, which achieves sustained virologic response in 50% or less, and often cause serious adverse effects. Now, new combinations of direct-acting antiviral agents are associated with very few adverse effects and generally result in SVR of over 95%. Nevertheless, detection, treatment, and monitoring of therapy continue to require special considerations in patients with CKD. Therefore, KDIGO formed a second independent guideline work group and evidence review team to update the KDIGO HCV guideline. This update was completed and is the subject of today's webinar. The guideline work group was led by Drs. Michel Jadoul and Paul Martin, and we are fortunate today to have Dr. Martin to give us a summary of this KDIGO guideline. Dr. Martin is Professor of Medicine and Chief of the Division of Hepatology at the University of Miami. He is an active clinician and clinical investigator who has published over 150 articles in leading peer-reviewed journals, and he is Editor-in-Chief of the journal Liver Transplantation. So I'll turn it over now to Dr. Martin.
Okay, good morning, everybody. Thank you, Bert, for that nice introduction. What I hope to do is give you an overview of what is in the update of the guidelines, which were last published in 2008. And in the intervening 9 years, an enormous amount has happened in the management of hepatitis C. And as Bert said, we've now gone from a situation where we had poorly tolerated, ineffective therapies as recently as 5 or 6 years ago to a situation where we can confidently expect to cure the vast majority of patients with hepatitis C with a finite course of well-tolerated therapy. As you heard, we have a multidisciplinary work group who has helped update the KDIGO guidelines on hepatitis C. Their names are listed here, and they incorporate the breadth and depth of medicine in the management of this group of patients. And we had members from across the globe. Here is a photograph of the group. In the interest of time, I'm not going to go through and identify all of them, but we worked very well together. We're very fortunate that Bert is one of the people working with us. Here is a draft of the updated practice guideline on the management of hepatitis C and chronic kidney disease. And as you can see, we address a number of important topics, not only the issue of antiviral therapy. Now let's quickly go through the guidelines. Now these are still a work in process. We hope to have finalized a version published within the next several weeks, certainly in PubMed. Now, first of all, detection and evaluation of hepatitis C and chronic kidney disease. We recommend screening all patients for hepatitis C infection at the time of initial evaluation of chronic kidney disease. And this recognizes the important role of hepatitis C as an etiological agent in at least some cases of chronic kidney disease. We currently recommend a serology, an immunoassay, followed by nucleic acid testing. And then we also recommend screening all patients for hepatitis C infection upon initiation of in-center hemodialysis or upon transferring to another dialysis facility or modality. And as the technology has evolved, we recommend either using NAT alone or an immunoassay followed by NAT. And we suspect that most centers will still start with an immunoassay. And what this slide illustrates is the rationale for testing for hepatitis C in patients presenting with chronic kidney disease. This is a large population-based study, and what it shows was that hepatitis C was implicated in the development of chronic kidney disease. And this observation has been confirmed in a number of other studies. And again, it reflects hepatitis C as an etiological agent in chronic kidney disease. Very importantly, antiviral therapy in patients with diabetes and renal dysfunction is associated with improved renal outcomes. So it's important to identify these patients and get them treated to prevent or mitigate progression of chronic kidney disease. The next part of this is we recommend assessing hepatitis C infected patients with chronic kidney disease for liver fibrosis, because we're not only managing a viral illness, we're also managing a liver disease. And we recommend an initial non-invasive evaluation of liver fibrosis. And increasingly, this is with the so-called FibroScan transient elastography, which is becoming increasingly available across the globe and has resulted in a marked decrease in the use of routine liver biopsy. However, the latter may still have a role if the non-invasive tests are inconclusive, or it's possible that, for instance, there may be another cause of liver disease, such as fatty liver, also coexisting in an individual patient with hepatitis C. And once we determine that a patient has advanced fibrosis, we also recommend assessment for portal hypertension. So, for instance, look for complications such as varices. The next one to pass on to chapter 2, which really is probably the part that has changed most in these guidelines, and we can now confidently recommend an interferon-free regimen, and secondly, that every patient with hepatitis C and chronic kidney disease is potentially a candidate for therapy. Now, there are several different regimens. These have been published in major journals, and our recommendation is that the choice of specific regimen be based on hepatitis C genotype, viral load, prior treatment history, drug-drug interactions, category of EGFR, stage of hepatic fibrosis, kidney and liver transplant candidacy, and comorbidity. So a lot of different ideas in there, but one of them is, again, we're not just managing a viral illness, we're also managing a liver disease. And then secondly, some of these patients would be candidates for organ transplantation, particularly renal transplant, and there's some nuances in terms of timing of antiviral therapy. Now, hepatitis C genotypes have been important, particularly in the interferon era. There's some important geographical differences. For instance, genotype 4 tends to predominate in the Middle East, whereas genotype 1 tends to predominate in North America and Western Europe. So the genotype is still pertinent, but less so now that we have pan-genotypic regimens that are effective for all genotypes. There are a variety of agents which have been developed as part of the strategy to treat hepatitis C with a multi-drug regimen. In essence, what these agents do is interfere with different parts of the hepatitis C replication cycle. And there are a lot of different drugs, and typically these are used in combinations of at least 2 or more drugs. There are some key characteristics and variability between the molecules, and one of the particular issues is their metabolism, because some of these drugs have predominantly renal metabolism, which may be a concern in a patient with more advanced chronic kidney disease. Secondly, for at least some of these regimens, there is the potential for drug-drug interactions. And one of the issues that's emerged is, even with these newer regimens, there may be a challenge with pre-existing or treatment-induced resistance. But a lot of these issues are being rapidly sorted out. But again, the key thing is these drugs are used as part of a combination regimen. Now, based on what we have available at present, we recommend that patients with an eGFR greater than 30 mL per minute be treated with any licensed direct-acting antiviral based regimen, so DAA regimen. We recommend that patients with a GFR less than 30 be treated again with a DAA regimen, but very importantly without the use of ribavirin. So ribavirin still has a role in the management of at least some patients with hepatitis C. Typically, patients who have a more complicated history, perhaps cirrhosis, or prior treatment ribavirin will continue to diminish generally, and particularly in chronic kidney disease, where it's a particular challenge using it because of its ability to cause anemia. Now, sofosbuvir has been one of the key drugs in the management of hepatitis C in this new era. There is some concern about its use in patients with eGFR less than 30 because of its renal excretion. There are some case series suggesting that it may be safely used in this circumstance, but very importantly, this is an off-label use. And the other concern has been whether progression of or worsening CKD may be a result of its use. So again, sofosbuvir has been a very important drug over the last few years, particularly as we manage more complicated patients, including patients with CKD. But there are some nuances with its use. And again, some of the newer regimens are probably going to obviate its use in patients with chronic kidney disease. This is a report of one of the key studies in this area. It was published in Lancet about a year and a half ago, and describes the use of sofosbuvir plus albasovir in treatment-naive and treatment-experienced patients with hepatitis C genotype 1 and advanced chronic kidney disease. And this is the so-called C-SURFER study. And very importantly, this can be administered as a single pill, and the endpoint was the percentage of patients who were virus-free 12 weeks after conclusion of therapy. Now, this study included some complicated patients. 75 or 76% of them were on dialysis. 6% of them also had cirrhosis, and many of them had been treated previously. And I won't dwell too much on the study's design. Suffice it to say that this was a relatively short regimen of 12 weeks. And as you can see, the overall sustained virological response rates were really excellent, and they were in the high 90s in both arms of this study, which used the same regimen. So again, these are really extraordinarily effective results in this very difficult to treat group of patients. And some of the attrition was related to loss to follow-up rather than virological failure. So again, I didn't dwell on the study design, but there was a placebo crossover arm, and very importantly, the tolerance in the active group was excellent. And again, this is really a very effective regimen in patients with hepatitis C genotype 1 with chronic kidney disease. This is a more recent publication, again, published in a high-profile journal earlier this year, which describes the use of lepapravir and pipravir in patients with hepatitis C and severe renal impairment. And this was over 100 patients, and as you can see from the genotype distribution, they were predominantly genotype 1, but other genotypes were represented also. 88% of the patients were on hemodialysis, and 58% were treatment naive. So that implies 42% of the patients had already failed a prior round of treatment. And again, what we saw were extraordinarily high sustained virological response rates, and again in the high 90s. So these are extraordinarily good results in what was correctly perceived as a difficult to treat population until very, very recently. Generally, this regimen was also well tolerated. There were some side effects that were reported, including pruritus and fatigue. But again, in a complicated group of patients, this regimen was extremely well tolerated. Now, this table is a synopsis of currently available regimens for use in patients with chronic kidney disease, stage 4 and 5, and based on hepatitis C genotype. And just one or two points about this. The first regimen I showed you for the so-called C surfer, from the so-called C surfer study. This is a compound developed by Merck, is efficacious in patients with genotype 1A, 1B, and genotype 4. The second study I showed you from the New England Journal of Medicine, the so-called GP regimen, is a pan-genotypic, so it's effective in all genotypes. Now, an important issue is who should be treated. And the feeling of the work group was that in most chronic kidney disease patients, the potential benefits of treating hepatitis C outweigh potential harm. Obviously, some clinical judgment is required. So if a patient has another major comorbidity, they perhaps are not a candidate for antiviral therapy. We don't believe any minimum life expectancy would justify treatment, but we did reference the AASLD guidelines, which were developed in association with the Infectious Disease Society of America. And in those guidelines, it's recommended that a patient have a life expectancy of at least 12 months to be a candidate for antiviral therapy. Now, another aspect of this is that most dialysis patients are on a variety of other medications, and there is a potential for drug-drug interaction. So that's certainly a consideration when treating dialysis patients or indeed patients with advanced chronic kidney disease, as well as renal transplant recipients. And this is a tool that's available on the internet, which helps identify interactions between commonly used drugs and the agents we're now using to treat hepatitis C. Another issue that has emerged over the last year or two has been reports that hepatitis B reactivation can occur in patients who have undergone antiviral therapy with these new regimens. And our recommendation was that patients should be tested for markers of either prior or current hepatitis B infection. Surface antigen, when it identifies current hepatitis B infection. Core antibody total identifies prior hepatitis B infection, and under that circumstance, a surface antibody may or may not be present. But if a patient does have hepatitis B markers that were not induced merely by vaccination, they should be monitored during treatment with serial liver function tests and a HBV DNA levels. And certainly if the patient surface antigen positive, it's probably appropriate to consider starting one of the oral hepatitis B agents prior to initiating therapy. And let's just touch on treating kidney transplant patients. They're certainly candidates for therapy, but importantly, if they're willing to accept a donor or an organ from a donor with hepatitis C, that may expedite their kidney transplant. And as a result, it may be appropriate to defer therapy until after kidney transplantation. And this is particularly important because there's increased interest in the United States of using grafts from hepatitis C positive donors. And again, what certainly we do at our center, and I suspect most North American centers, we work in collaboration with the renal transplant team to determine whether kidney transplant candidates should be treated before or after renal transplant. And there's good evidence or emerging evidence supporting the safety of using Hep C positive organs in Hep C infected recipients. So certainly if we treat patients before kidney transplant, we can clear the hepatitis C and abort progression of the kidney, liver and kidney disease. And particularly if the patient has a glomerulonephritis related to hepatitis C, we may be able to control it better. We may potentially block the impact of hepatitis C and other adverse outcomes, including new onset diabetes following renal transplant. The counter argument is by eradicating the hepatitis C in a renal transplant candidate, they no longer have access to organs from hepatitis C infected donors. So again, it's a judgment call and should be part of the discussion between the treating doctors and the renal transplant centers. This is again a recent study looking at the use of antiviral therapy for 12 or 24 weeks in kidney transplant recipients with chronic hepatitis C, and the particular very impressive, 100% sustained virological response rates. This just summarizes the available regimens, again, for patients with chronic kidney disease based on a particular genotype. And again, there is a concern about the use of sulfoxaflor in patients with more advanced chronic kidney disease. The next thing that we discussed in the guidelines was prevention of hepatitis C transmission in hemodialysis units. And we strongly recommended that hemodialysis facilities adhere to standard infection control procedures, including hygienic precautions that effectively prevent transfer of blood and blood-contaminated fluids between patients to prevent transmission of blood-borne pathogens. And there are a number of, we suggest to implement this, including regular observation audits of infection control procedures in the hemodialysis units. We recommended not using dedicated dialysis machines because the literature does not support that as an effective way to prevent transmission. We suggest not isolating hepatitis C infected dialysis patients, and we suggest that dialyzers of hepatitis C infected patients can be we recommend that dialysis centers examine and track all hepatitis C test results to identify new cases of hepatitis C infections in their patients. We recommend aggressive measures be taken to improve hand hygiene and proper glove use, injection safety, and environmental cleaning and disinfection when a new case of hepatitis C is identified that is likely to be dialysis related. And then we after kidney transplant. And then finally, if receiving a kidney from a hepatitis C positive donor improves the chances for transplantation, the hepatitis C positive patient can now undergo transplantation with a hepatitis C positive kidney and be treated for hepatitis C infection after transplantation. We recommend that all kidney donors be screened for hepatitis C infection with both immunoassay and NAT if available. And in our current state of knowledge, we recommend that transplantation of kidneys from hepatitis C viremic donors be directed to recipients with a positive NAT. After the assessment of liver fibrosis potential, hepatitis C positive living kidney donors who do not have cirrhosis should undergo hepatitis C treatment before donation. They can be accepted for donation if they achieve sustained virological response and remain otherwise eligible to be a donor. So our concern here was the small risk of potentially transmitting hepatitis C via live kidney donation. Now, there have been some exciting reports describing the use of hepatitis C positive donors for hepatitis C negative recipients. This is clearly investigational, but early reports suggest that these patients, following receipt of a kidney from an infected donor, can be successfully treated to prevent progression of hepatitis C infection acquired at the time of kidney transplant. Again, but I would emphasize this is very new and is still investigational. The final issues we addressed were the diagnosis and management of kidney diseases associated with hepatitis C infection. And we recommended that a kidney biopsy be performed in hepatitis C infected patients with clinical evidence of glomerular disease. We also recommended that patients with hepatitis C associated glomerular disease be treated for hepatitis C. We recommend that patients with hepatitis C related glomerular disease showing stable kidney function and are non-nephrotic range proteinuria can be treated initially with these new oral direct-acting agents. We recommend that patients with a cryoglobulinemic flare, nephrotic syndrome, or progressive kidney failure be treated in addition with antiviral therapy with immunosuppressive agents and our plasma exchange. And clearly this is very much on a case-by-case basis. We recommend immunosuppressive therapy in patients with histologically active hepatitis C associated with glomerular disease who do not respond to antiviral therapy, particularly those with cryoglobulinemia, get an immunosuppressive agent such as rituximab. And we believe that this is the first line agent under these circumstances. So I've covered a lot of ground and information here. As I said, these guidelines are now in the final state of approval and should be available online very, very shortly. So this is clearly an exciting time for those involved in the battle against hepatitis C, the chronic kidney disease, dialysis, and transplant population. Major progress in the treatment of hepatitis C chronic kidney disease patients, and they're really impressive data, and we can assure the vast majority of patients they can be cured with one course of therapy. But we can't be complacent. We need to identify every hepatitis C infected patient with chronic kidney disease, get them to an individual who's prepared to consider antiviral therapy. These drugs are generally easy to use, but again, there is the potential for drug-to-drug interactions. There may be some change in certain drug levels as liver function improves as a result of therapy. There has been concern that in patients with more advanced cirrhosis, that liver disease may progress during antiviral therapy. So that's certainly in consideration. The reactivation of hepatitis B, I've mentioned, and that has remained a concern based on a relatively small number of reports. And then finally, the collaboration between hepatologists and nephrologists is the key for success. So I would like to thank you for participating. I would like to apologize for the late start, and which is my fault. And again, we've some time now, I believe, for questions. Thank you so much.
Paul, thank you very much for an excellent summary in a few minutes of what took 2 to 3 years actually to develop these guidelines. Paul, I have a kind of a question for you here, and this is all unrehearsed. But recently there's been a little controversy. There was a Cochrane review of the randomized trials of the antiviral agents, and the Cochrane review apparently suggested that reminded everyone that sustained virologic response is a surrogate outcome for, of course, survival and quality-adjusted life years and whatnot. And so they kind of, look to hedge a little bit. And yet, the FDA and almost everyone else in the field has, really felt strongly that the SVRs are truly a good surrogate outcome, and that the results of the trials and the recommendations should stand as a result of that. So I wonder if you have a comment on that.
Yes. So I think myself and every hepatologist in North America and Western Europe has already personally observed the effect of these new regimens on patients with hepatitis C. And there are a few very important endpoints. And one of them is the number of hepatitis C patients coming to liver transplantation appears to be diminishing. There are a large number of studies, including some population-based studies from Taiwan, unequivocally showing that successful antiviral therapy for hepatitis C results in both improved liver outcomes, but also patient outcomes. The mortality rate diminished. So I think unequivocally treatment benefits patients.
Sure. So the first question is, what is the benefit of grazoprevir, elbasvir therapy over ritonavir and paritaprevir, ombitasvir combination in stage 4 or 5 CKD?
Okay, so that's a good question. There are no direct head-to-head comparisons. So we're comparing across studies rather than the usual prospective controlled clinical trials. I think part of it, particularly in the CKD population, there are two aspects. First of all, there are the virological outcomes, but secondly, there are also the tolerability issues. And I think what was most impressive about the abasvir study was the excellent tolerability. And the way the study was designed, there was, as I said, there was a crossover study. So there was a placebo arm for 12 weeks. And they had the same rate of side effects as the people on therapy. So I think in terms of tolerability, there's probably an advantage to the abasvir regimen. But again, that's in the absence of head-to-head comparisons.
Okay, thank you, Dr. Martin. This was a question by Dr. Mashali. Second question is a question by Dr. Viloria, and it's, after the treatment of HCV, is it necessary to check for PCR, HCV RNA, and how frequently, and what other blood works to check?
Sure. Okay. So the benchmark is, or the gold standard is an HCV RNA 12 weeks following completion of therapy. If that is negative, the patient is cured of hepatitis C. But I think most of us like to get at least one or two more RNA tests over the next several months, even though the rate of relapse is extraordinarily low. And the finding, if the patient becomes viremic, having been negative at 12 weeks following completion of therapy, it suggests they've been freshly reinfected. Secondly, we're also managing a liver disease, and that's why assessment of fibrosis is so important as part of the workup. If you know the patient has very mild liver disease, once you cure the hepatitis C, they don't require any additional follow-up apart from their routine medical care. In contrast, if you know they have advanced fibrosis, they do require follow-up, and I would recommend doing an ultrasound every 6 months to screen for hepatocellular carcinoma, and also reassessing the severity of the fibrosis, perhaps with a repeat fibroscan in a year or two, because the hope would be that the fibrosis would diminish.
Okay.
I now see the questions here. So
go ahead.
Next question is kindly add something on the current nutritional guidelines. Paul, do you have any comments about nutrition and HCV patients?
Yeah, well, the one aspect of nutrition we tend to emphasize is they shouldn't be drinking alcohol on any sort of a regular basis, because that clearly accelerates hepatitis C progression. But from my perspective, they should be just following the real diet recommendations rather than anything specific to the liver.
Right. Another question, I ask if the patient has serum creatinine above 1.5 to 2 or above, should we start treatment with DAAs or wait till improvement of their kidney function?
Well, it depends what the etiology of the renal dysfunction is. If it's some intercurrent event, I don't think in most patients there's no urgency to treat, so I would wait until the creatinine settles down to the baseline.
Data on improvement in renal function have been shown in studies with HCV patients who achieve SVR with interferon-based regimens. Do you know if there are additional studies showing improvement of renal outcomes with DAA therapies?
Well, I think there are case reports and case series, but realistically, these drugs have been only licensed for the last few years, so we don't really have a lot of long-term data. There are a few studies that I'm aware of looking at populations and in the VA and elsewhere, suggesting that progression of chronic kidney disease is aborted with successful antiviral therapy.
Another question, could the use of these new antiretroviral regimens lead to complete remission?
Of the kidney disease, you mean?
Well, that's just the question. I would think so.
Okay, well, the answer, so first of all, regression of the liver disease unequivocally occurs. So fibrosis diminishes. What's unclear is whether the risk of hepatocellular carcinoma in patients with cirrhosis ever goes away completely, even if the fibrosis regresses. So I think it's prudent to continue screening those patients for hepatocellular carcinoma.
Okay. The next question, I have a male patient, 56 years old, presented with hematuria, raised kidney function, blood pressure normal, low complements, and he's HCV positive, presented now with massive edema, normotensive, raised renal chemistry, and raised PCR of HCV. How to treat?
Well, I would defer to my nephrology colleague, but it seems to me this is a patient who probably requires immunosuppressive therapy as well as antiviral therapy.
Right. Personally, I think the patient needs a biopsy so we have a more accurate histologic diagnosis of what's going on, and that could help guide the renal therapy part of it. But eventually this patient will be undoubtedly treated for the HCV. Next question. My question is to better treat kidney transplantation recipients before or after transplant, since pharmacodynamics of sovosivir are not available in CKD stage 4 or 5, and most regimens initially tried off-label use sovosivir. Your personal opinion regarding treatment before or after transplant in case of living donor ready and fit for donation?
Yeah. Okay, so these are very short duration regimens, and I would favor treating the hepatitis C pre-kidney transplant to prevent possible effects of hepatitis C infection, including injury to the renal graft and onset of diabetes post-transplant.
Okay, here's a good question. Is there any rule for adding any antiviral treatment for HBV, hepatitis B, lamivudine or entecavir with DAA for patients infected with both HCV and HBV to prevent HBV flare?
Yes, okay. So it depends on the hepatitis B serologies. If they're surface antigen positive, I would put them on one of the frontline hepatitis B agents, and that means either tenofovir or entecavir. If they have if they're surface antigen negative but have a positive core antibody, they can probably do fine with lamivudine, which is cheaper and is effective in preventing reactivation. But again, if they're surface antigen positive, I would treat them with the two agents I mentioned, tenofovir or entecavir. Are
we authorized to use a non-tested protocol to treat all types of hepatitis genotypes if it is the only one available locally?
Well, that's a difficult question. I think it's very much on a case-by-case basis. I think the particular challenge is using sofosbuvir with a GFR less than 30. So again, that's off-label. I can tell you anecdotally, we certainly used it here, but we monitor those patients very carefully. But it is not licensed for a GFR less than 30.
Okay, another question: is there if there is a suspected cause of renal impairment, such as diabetic kidney disease, should the antiviral therapy be started as well? Is there any role for biopsy in such case?
Well, as regards to the antiviral therapy, I would certainly endorse its use because it's been implicated in progression of chronic kidney disease, whether other etiological factors. As regards to renal biopsy, I would defer to Bert on that.
Yeah. Well, I think this is a little bit of a judgment call, depending on the patient's preferences and whatnot. But personally, I would probably do a biopsy just to sort out how much of this is diabetic nephropathy versus if there is possible underlying other glomerular disease or something going on in this patient. So, and it would be maybe helpful prognostically too to see how much kidney damage and whatnot. But it is a subjective opinion, I think. I think we have one more question here. In patients with renal transplant with HCV infection and high PCR and creatinine 4, which is rising pending renal biopsy results, should we start treatment or wait for the biopsy result, and why?
I would wait for the renal biopsy results because clearly there are a number of differentials,
Right.
and hepatitis C might be dental.
Right. I from a nephrology point, I would agree with that entirely. So I will. It's at the top of the hour. I will thank all of these are all excellent questions, and I may have skipped over a couple of them for interest of time here, but thank you all for all your questions, and Paul, thank you for your excellent summary, and so I think I'll close out this webinar.
Okay, thank you, and